Good morning, respected dignitaries and colleagues. I welcome you all for today's combined clinical round assigned to Department of Cardiac Anaesthesiology. I am here to give you a brief about the department and our functioning. To start with, our journey started around in 2012. We were part of many landmarks achieved by the CTVS department. Along with them during this period, department established in 2012 as a subspecialty to the Department of Anaesthesiology. We were part of heart transplant, heart lung transplant in 2015 and 2017 respectively. NMC recognized us as a specialty department in 2018 and allotted us with 2 DM seats. In 2022, liver transplant team include us, and we did first awake CABG in the state of Rajasthan in 2024. Currently, we have 2 DM cardiac anesthesia candidates enrolled with us. Initially, we started with 3 consultants, and 2 of them are still with us. Right now, we have 1 professor, 3 associate professor, and 1 assistant professor in our department. So, little bit about what we do. So, contrary to the general perception, services of cardiac anesthesia department are not only limited to perioperative care of CABGs and valve replacement surgeries, but to many other domains. We provide anesthesia to mediastinal, thoracic, vascular, and lung surgeries also, which require 1 lung ventilation and newer techniques. Our responsibility is not only monitoring and maintaining the hemodynamics, but also we assisted in diagnostic and assessment of cardiac function during surgery through the transesophageal echocardiography. T is a type of a echocardiography where a probe is inserted into the esophagus, and continuous 2D echocardiogram can be seen intraoperatively to all of us. So, assessment of surgery, results of surgery can be seen immediately during intraoperative period through this. Our 24/7 on-floor presence makes things little simpler in acute life-threatening situations. Last week, 1 such patient with ruptured aortic aneurysm come to emergency in odd hours, and as part of CTVS team, we were able to take this patient in OT without wasting precious time. As cardiac surgery moving more and more towards non-invasive procedures, we adapted ourselves and modified our anesthesia techniques in accordance with the ERAS protocols and provided with the newer blocks, regional blocks to discharge patient early. Pediatric Cardiac Sciences Center in MGH provides complete surgical and medical treatment to complex congenital heart diseases of neonates of less than 2 hours of age and less than 2 kg. Anesthesia management of complex congenital heart surgeries are presenting more challenging scenarios for the anesthesiologist. Babies may have syndromic association, other congenital abnormalities, difficult airway and IV accesses. They have altered circulatory physiology. Proper understanding of systemic effect of these altered physiology is a key concern for the pediatric cardiac anesthesiologist. Effect of mixing and shunting of blood between the right and left heart makes sudden changes in the plasma levels of anesthesia drug. Anesthesia drug causes systemic vasodilatation, and therefore reduction in venous return may result in reduced pulmonary blood flow, which is detrimental to already cyanotic baby. Non-operating room cardiac anesthesia services provided by the department require advanced level of expertise. Providing sedation for diagnostic cath and device placement or contrast CT out of OT in hemodynamically unstable patient can drain all adrenaline reserves of anesthesiologists in few seconds. Department is involved in liver transplant program and also always happy to provide ancillary services for cardiac patients posted for non-cardiac surgery if someone needs us. So, our workload is distributed between the Department of Adult CTVS, Department of Pediatric CTVS, Pediatric Cardiology and Liver Transplant Surgery. Last month we did around 50 CTVS adult cases with 24/7 perioperative care, 20 pediatric complex congenital cases, surgical, 12 major pediatric cardiology cath lab procedure and 5 liver transplant procedures. Our yearly average data comes around 480 adult CTVS cases, which is shown in blue bars here. 250 pediatric CTVS cases shown in green, and 220 NORA cases orange, with 47 last year liver transplant programs, which are shown in violet one. This graph shows case-wise distribution of our adult and pediatric services. Department is very active in research and publication. We have 4 high-quality research papers published in Q1 journals in last 3 years. As mentioned before, department has NMC recognized 2 DM anesthesia seats. We have robust regular academic activities, workshops, CMEs for our DM and MD students. Our DM student Dr. Saiteja presented case series of 5 cases of anesthesia consideration and management of L kappa repair surgery. This is a rare kind of a congenital defect taken care only by few centers in India. At ACTA National Conference in Vizag, this is a national conference of cardiac anesthesiologists this year, which was appreciated both by invigilators and delegates as well. Department gets timely media coverage for its good work time to time. We were highlighted our role in heart transplant, liver transplant, and transcatheter aortic valve implantation, and conducting CABG under regional anesthesia. So how cardiac anesthesia is different? This is for my younger colleagues who are interested in cardiac anesthesia to understand that expertise in hemodynamic management with efficient use of vasoactive drugs, advanced hemodynamic monitoring, knowledge of advanced gadgets like TEE, pacemakers, and IABP make cardiac anesthesiologists different from other medical streams. And now I am inviting Dr. Nishit to present today's case. Thank you very much.
Thank you, Dr. Gaurav, sir. Good morning, everyone. I am Dr. Nishit Patel, a second-year junior resident of Department of Pediatrics, and today I will be presenting CCR under the valuable guidance of Dr. Sanjay Khatri. This case is a 45-day-old male child named ABC, resident of Jaipur, Rajasthan. The information for this case has been provided by the mother, who is reliable informant. Baby present with a bluish discoloration of nails, lips since 2 weeks. Interrupted feeding since last 3 to 4 days. The child was apparently well until 2 weeks ago, when mother noticed a bluish discoloration of tongue, skin, nails. Bluish discoloration was gradually in onset and has progressively increased over the last 3 to 4 days. Since the past 3 to 4 days, the child has developed interrupted feeding, characterized by poor sucking, frequently pause during feeding, easy fatigability, increased duration of feed, sweating mainly over forehead during feeds, indicating abnormal suck-rest cycle. Baby with abnormal suck-rest cycle suck for few seconds, then become breathless and prolong pause, and then resume feeding. There was no history of anisotropy, no history of respiratory infection, no history of fever, no family history of congenital heart disease and sudden cardiac death, no history of neonatal jaundice. There was no maternal history of fever with rash, diabetic mellitus, hypertension, or thyroid disorder during antenatal history. There is no history of teratogenic drug intake, alcohol, smoking, or substance abuse. The antenatal screening was done, which show a routine investigation and no anomaly detected on antenatal ultrasound. The mother perceived normal fetal movement throughout the pregnancy. The baby was born at the term 38 week of gestation via elective LACS. Cry immediately after birth. Birth weight was 2.8 kg. The baby received all birth vaccination, BCG, OPV, hepatitis B as per the national immunization schedule. The baby was born out of non-contiguous marriage. There is no history of similar illness in the family on either the paternal or maternal side. In these 3 generations, the pedigree chart. The pedigree chart, we can see that there is no significant history in the last 2 generations. To summarize the history, we have 45-day-old male child, full-term elective LACS with normal antenatal and postnatal history. The baby present with bluish discoloration of tongue, lip, nail, and since 2 weeks with progressive worsening, associated with interrupted feeding since past 3 to 4 days. Now, with the above summary, I would like to ask the audience, what all the differentiation can we think of? Uh, yes, you are right. The infant with general uniform cyanosis with feeding difficulty and possible differentiation.
Why hemoglobinopathies? Which hemoglobinopathy can produce a picture like this?
Yeah, indirectly cardiac overload.
No. So there is obviously a left to right shunt happening, and happening at a very early age and not at birth. So that should kind of narrow down your possibilities, no? But no hemoglobinopathies. That I don't think we would consider. Would we consider that?
The in the infant with generalized uniform cyanosis with feeding difficulty, possible differences include both cardiac and non-cardiac cause. The non-cardiac cause can be hemoglobinopathy or respiratory, and cardiac cause can be cyanotic congenital heart disease. In with this with this with this history, we can say that a mostly favor the cyanotic congenital heart disease. The cyanotic congenital heart disease can be classified into the decreased pulmonary blood flow and increased pulmonary flow. With this history, we can say that the baby present with suck rest suck cycle and profuse sweating over the forehead and scalp, which is clinical classic sign for congenital cardiac failure in infants. General physical examination. At the time of examination, baby was comfortable sitting on the lap of mother. On examination, baby was cyanotic with saturation of 60% on room air in right upper limb. Rest vital were within normal limit. Head and face appear normal in shape, no facial dimorphism, and eye appear normal. In eye, no icterus or no cataract was present. There is generalized uniform cyanosis was present, and mouth with bluish discoloration of oral mucosa, good oral hygiene, no cleft palate. There is no scars and no visible deformity on chest. Hydration status adequate and no signs of dehydration. The associate syndrome appearance was absent from the general physical examination, thereby making genetic syndrome less likely. Systemic examination. Cardiovascular system, there is no precordial bulge, scar mark, and venous prominence. No visible impulse over precordium. On palpation, the apex fluid at the left foot intercostal space 1 centimeter outside a mid-clavicular line. No left parasternal heave present. Thrill absent. The epigastric pulsation is not present. On auscultation, S1 is a normal S1 sound is a normal intensity, and S2 is single and loud. On auscultation, no murmur was heard. Examination of all other system was within normal limits. To proceed toward investigation, the hematological and biochemical parameters were normal. In view of suspected cyanosis heart disease, the chest X-ray was done. This is the APV of chest X-ray, which show a heart appear globular due to the abnormal convexity of right atrium border and left atrium enlargement, giving X-shaped appearance. Superior mediastinum appear narrow due to the stress-induced thymic atrophy, in which the arterial position is present in anterior posteriorly, giving a string-like appearance, which give the egg-on string appearance, which is a classical sign for the transposition of great arteries. To confirm the diagnosis and identify the structural cardiac defect, we done the 2D echo, showing the left ventricle give rise to the vessel which is bifurcating, that is pulmonary artery, and RV give origin to the vessels which is not bifurcating and give origin to the coronaries. So aorta arise from the right ventricle. The echocardiograph findings suggestive transposition of great arteries with small fossa ovalis ASD 3 to 4 mm shunting left to right, intake IVC. Aorta arise from the right ventricular, pulmonary artery arise from the left ventricular, tiny PDA shunting left to right, dilated LA and LV, and normal ventricular function. To summarize, we have the 45-day-old male child with generalized uniform cyanosis since last 2 weeks, associated with interrupted feeding since last 3 to 4 days, Systemic examination revealed S2 single and no murmur. Appearance of silent cyanosis. Chest X-ray and 2D echo confirm the diagnosis of transposition of great arteries. Now, I would like to call Dr. Vini Mehta, a senior resident from the Department of CTVS, to take case forward.
Thank you, Dr. Nishit. Good morning, everyone. I'm Dr. Vini Mehta from the Senior Resident from the Department of CTVS. So what is TGA? The transposition of great arteries has an incidence of 1 in 3,500 to 4,000 live births. That accounts for 3 to 7% of all congenital heart diseases. To understand, we will compare the circulation of a normal heart to that having a TGA. In a normal heart, deoxygenated blood is received from the body through the SVC and IVC. Received to the body through the SVC and IVC. And then it reaches the right ventricle, and then from the pulmonary artery it reaches the lung for oxygenation, then it reaches to the left atrium, then to the left ventricle, then through aorta to the systemic circulation. That is called as a series circulation. But in case of TGA, the right ventricle is giving rise to the right ventricle is giving rise to the aorta, and the left ventricle is giving rise to the pulmonary artery. Therefore, the oxygenated blood will remain oxygenated and the deoxygenated blood will remain deoxygenated only. This is called as parallel circulation. So, definitive repair in such cases is surgery. We had two choices in this case, either to go for arterial switch or an atrial switch. After birth, the previously non-functional right ventricle becomes functional due to the reduction in pulmonary vascular resistance, because as the lungs will expand after birth. In this case, it is the left ventricle that is connecting to the pulmonary circulation, so it does not get adapted to the systemic circulation. Therefore, it regresses after 30 days of life, that is approximately 4 weeks of life. So, therefore, before 30 days of life, when LV is prepared, we can go for arterial switch. But post 30 days, we will have to go for the atrial switch. Our patient was 45 days old infant, but his LV was still functional. We opted for the arterial switch operation here. Reason behind the preparedness of left ventricle was still not clear, and it will be identified intraoperatively. That is, if there is any connection between the pulmonary and the systemic circulation, which was not identified earlier in transthoracic echocardiography. In arterial switch, we exchange the position of the great arteries, that the pulmonary artery will be exchanged with the aorta, and in atrial switch, we'll put a baffle which will transpose the atrias. We will see the surgical steps later. Before that, we handed over the patient to the Department of Cardiac Anesthesia for pre-anesthetic workup. Now I invite Dr. Saiteja.
Good morning, everyone. I am Dr. Saiteja from the Department of Cardiac Anesthesia. Firstly, I thank Dr. Vini for the introduction and the excellent overview about the case. As the baby is planned for the surgical correction of TGA, I will now discuss about the preoperative anesthesia checkup, evaluation and everything. Coming to the preoperative assessment, it focuses on mainly evaluating the adequacy of the mixing and the severity of the disease and the preparedness of the baby for surgical surgery, stress, everything. So in this preoperative assessment, we take a detailed history of presenting illness, how the baby is presented, like how frequent the baby is having the symptoms and how are the severity of the symptoms, and then associated anomalies, and then cyanotic episodes if anything is there, and then investigations coming to that. In our case, the chest X-ray shows the account string appearance, which is confirmative of the TGA, and then suspicion of the TGA, and then cardiac echograph done, which suspects of transposition of great arteries. And then coming to the current hemodynamic state of the baby, baby is stable and without any inotropic support, but we have to examine the basal vitals of the baby, which are having baseline low SpO2 saturation, and then airway assessment shows normal airway without any abnormalities detected, and then in cardiac examination and respiratory examination, it shows the previously as discussed, S2 is loud and then no murmurs, which is a silent TGA. And then after reviewing of all the records, we come to the diagnosis of TGA and then confirm the diagnosis and then surgical plan of corrective procedure, corrective change of the TGA thing. And then in this picture we show so many abnormalities can be suspected in these babies usually, but we are only focused on airway vascular thing, which is very difficult in these small childs to secure the lines, and then any like differentiation of the arterial and the venous system. And then coming to the lungs, it will be difficult for the babies to have the respiratory reserve, so we have to check assess the thing before the surgery. And then the immunological state of the baby for any post-operative infectious and then intraoperative antibiotic prophylaxis to be started immediately. And what we are concerned about is like preoperative cardiac status. In this baby, the hemodynamics are stable and not on any inotropic support. And the respiratory system, we are having the baseline saturation is low, and then no compensatory reserve for the intraoperative induction period. So it will be difficult for us to it is difficult for us to maintain the saturation at the time of induction. So we have taken so much concern about this, and then prepared for everything for the difficult ventilation and the difficult airway. And then developmental status and anomalies are not there in this case. And the surgical plan is of corrective procedure of switching of the arteries. And then coming to the pediatric airway assessment, mainly it is not a small airway compared to the adult, but the main changes are like tongue will be larger and epiglottis will be floppy, and then it will be obscure our visualization during the laryngoscopy. And then vocal cords are anterior, and then larynx is positioned higher, and then cricoid is the smallest part of the airway. And then in this endoscopic view, we can see epiglottic and subglottic edema is there. So we prepared for everything for the difficult intubation, and the laryngospasm can happen, so that we prepared for the all the emergency drugs, and then bronchoscopy is ready. On the day of surgery, proper counseling and consent was taken from the parents before shifting regarding the possible risks and outcomes of the intraoperative and postoperative period. And then the baby shifted to the operative theater under observation of anesthesiologist in a cool and calm way without any hesitation, covered with the blankets to prevent the hypothermia. And then during the intraoperative period, after the baby was shifted to the OT, the checklist of patient identity, procedure and consent was confirmed, ensuring equipment, drugs and emergency readiness in the OT. After that, standard basic monitors regarding the ASA guidelines were connected and baseline vitals were recorded. Induction of anesthesia was started with ketamine to maintain the SVR, and then to prevent to maintain the hemodynamics of the baby, as these babies are mainly prone for the hypotension, which is very catastrophic for us to maintain to manage in the OT. And then intubation was done using a appropriate size ET tube under direct laryngoscopy. In this case, we used 4 size ET tube and fixed at 9.85 centimeters at the lip level. And then ventilation was baby was connected to the ventilator with the lung protective ventilatory settings. In this case, we connected we just maintained tidal volume of 35 ml and respirated of 45 breaths per minute and PEEP of 5 centimeters H2O water. And then coming to that, next we have to secure the central line and artery line, which is very difficult for in these babies, which are because they are fragile, and then very thin veins and then thin arteries will be there, and it will be difficult for us to differentiate from the arterial and venous blood also. So the maintenance of the anesthesia is like a normal fentanyl, midazolam, acronym, isoflurane to maintain the baseline hemodynamics stable. And then in this video we can see insertion of the central line in this baby. Usually after the introducer needle is inserted, and then backflow of the blood is seen in this introducer needle, and then guide wire is inserted and dilated with the dilator, and then a 4.5 mm of triple lumen CVC catheter is inserted. And then mainly we have to confirm with the connection of the CVC catheter to the monitor only. In these cases, we cannot differentiate from like in a normal way, like differentiating from the blood color and then waveform flow of the blood, or else we cannot do any USG probe guidance because they will be having short neck. So it will be challenging for us to do it in the OT. And then in this video we can see insertion of a right radial arterial line was done using in the palpation method. In this video we can see the left femoral line was done using the like palpation method, inserting a needle and then introducing a guide wire and then inserting the catheter and connecting to the monitor for the continuous intraoperative invasive BP monitoring for maintaining the monitoring the hemodynamics. Okay. Even after so much of precautions taken during induction, the baby had a episode of cyanosis, which was diagnosed after seeing the sudden fall in the EtCO2 and then saturation. As we see, the saturation is 19 only, with 100% of FiO2. So we just confirmed with the after taking an ABG. In the ABG, we can see PaO2 of 12 and then SO2 of 11.2, which even after maintaining FiO2 of 100%. So that we just recognize the situation and then manage it accordingly. In this management, we just initially airway was assessed and checked for patency to avoid further hypercapnia and hypoxia. Circulatory support was given with fluid resuscitation and then with the inotropes, vasodilators were started. PVR is maintained PVR is to be reduced to shift the patient blood from the pulmonary to the systemic return. So PVR should be increased then by deepening the anesthesia plane, and then calcium infusion started to support the baby's heart, like it will increase the myocardial contractility and support the circulatory system. After this, after the cyanotic episode, the monitor looks like this, maintaining the saturation of 31. Even though it's not a normal range, but usually we used to see this saturation in the OT, and then we should proceed this. And then for this monitor, for these vitals, we have to shift the baby onto the cardiopulmonary bypass machine only. So we asked the surgeon, we just introduce everyone to do the their respective roles to initiate the CPP, and then CPP was initiated. Putting on a patient on CPP is in a cardiac surgery involves a structured team-based approach. It initially priming the circuit and then connecting to the lights. Before that, we should give before connecting to the lights, before cannulating the patient, heparin should be given to maintain the ACT to prevent clotting. With an ACT of more than 400 to 480 seconds. ACT means like activated clotting time. Now I will invite Dr. Vini to proceed for the next surgical steps.
Thank you, Dr. Sain. Before we see the video of the surgical steps, here is a diagrammatic representation of the surgery. In the first image, we can see the aorta arising from the right ventricle and the pulmonary artery behind it from the left ventricle, whereas it should have been reversed normally. In arterial switch operation, aorta and the pulmonary artery are exchanged. The coronary buttons from the aorta are harvested and then transferred onto the pulmonary artery, which will now become the neo-aorta. And after the harvesting of the coronary buttons from the aorta, this gap will be filled using this pericardial patch, and then it is anastomosed to the distal end to form the neopulmonary artery. To make it more simpler, here we can see this is the anatomy of the TGA, transposition of great artery, in which aorta is arising from the right ventricle and pulmonary artery is arising from the left ventricle. That is the reverse of the normal heart. So first we will transect this aorta, and then after transecting we will harvest the coronary buttons, and after harvesting the coronary buttons we will transect the pulmonary artery. The pulmonary artery has to match this will become the neo aorta now, so this has to match the caliber of the distal aortic end. So we do the reduction plasty of this. After reduction plasty of this, we will make holes for the coronary transfer. So we make a incision over this aorta, 2 incisions for transfer of the both coronaries, and then we will transfer these coronaries harvested from here to this neo aorta and connected to the distal end, which will form the neo aorta. And the remaining part of this this pulmonary aorta, previous aorta, which will now become the new pulmonary artery, from where the coronary buttons were harvested. This part, this gap will be filled using a pericardial patch. This is the pericardial patch will be used to fill the gap and then connected to the distal end to form the neopulmonary artery. And then in the end, we got it reversed. That is in the original anatomy of the heart, where the pulmonary artery is arising from the right ventricle and the aorta is arising from the left ventricle. This is a small video of the arterial switch operation. This will be the caudal end, this will be the cranial end. After sternotomy, we can see the aorta arising from the right ventricle anteriorly and main pulmonary artery behind it from the left ventricle of behind the aorta. And we harvested the great artery, separated the great arteries from the structures below. After aortic cannulation for cardiopulmonary bypass, we have tucked the two ends of patent ductus arteriosus using sutures. Here the PDA is being divided and the cut ends are visible. We are also mobilizing the left pulmonary artery. After that, we found two collaterals arising from the descending aorta connecting to the pulmonary artery, being the reason for the preparedness of the left ventricle. These collaterals were then ligated. We did an epicardial echo showing the flow through the collaterals initially when they were not ligated, and then laminar flow is visible after the ligation of these collaterals. Marking sutures were then placed over the pulmonary artery for future left coronary button implantation, which is going to be the new aorta. Now the right side marking sutures are being placed, as well as we will mark the transection site of the aorta. This is the first step we are doing here. We are going to mark the site of the transection. Now we cannulated the inferior vena cava for cardiopulmonary bypass to be initiated. And then a cross clamp will be applied over the aorta to give high potassium containing solution, which is called as cardioplegia, which will arrest the heart and give us bloodless feel for surgical repair. Ice cold solution is being poured over the heart for surface cooling. In no. Yeah. We are making marking the site of transection over the aorta. After this, we are cannulating the IVC for cardiopulmonary bypass to be initiated. And now we are applying a cross clamp over the aorta to give a high potassium containing solution called as cardioplegia, which will arrest the heart and give us bloodless surgical field. Ice cold solution is being poured over the heart for surface cooling. Now we are opening the right atrium to reach for the left side of the heart for its decompression through patent foramen ovale. We will put a vent through it. Now we are transecting the aorta, which is arising from the right ventricle, over the previously marked site. Checking the position and course of the coronaries will also be done. That's how we are checking the course of the coronaries. Aorta is further mobilized, which is now the proximal end of the neopulmonary artery. And again we will check for the course of the coronaries. and extend the dissection further. Now we started with the harvesting of the coronary buttons. The right coronary button is harvested first. This is the right coronary button being harvested, and then the left coronary button is harvested from the original aorta. After harvesting is being completed, the proximal end will form the new pulmonary artery, but the valve will still be aortic. Now we are mobilizing the pulmonary artery, which is arising from the left ventricle, and transecting it as well. Now we are extending the incision, and the pulmonary artery is now being transected completely. We can see the cut ends. This end which we are tucking now will become the neo aorta. But it has to match the caliber size of the distal aorta, so we will do a reduction plasty here. This reduction plasty is done using scissors, and the lateral end will be sutured using Proline 70 sutures. After this, we will check for the competency of the aortic valve with saline. That's how we are checking the competency of the valve. Now the posterior wall of the neo aorta is constructed. Now an incision is being made over the new aortic valve for the transfer of the coronary buttons. First, we will transfer the left coronary button. We harvested the right one first, but we will transfer the left coronary button first over the new aorta after confirming its lie. Here we are suturing the left coronary button over the aorta. Now it has been completely done. Then we will further close the aortic valve to have proper lie of the right coronary button. Now we are making space for the right coronary button implantation. This is the right coronary button being implanted over the new aorta. The technique used in this implantation or transfer of the coronary buttons is called trapdoor technique. Now we will close the remaining part of the anterior aorta, anterior aortic valve, using Proline sutures again. But before completely closing this aortic valve, we will put a cardioplegia again to check the competency and the flow through the coronaries. Now we are using a treated pericardial patch to cover the defects of the new pulmonary artery from where the coronary buttons were initially harvested. The patch plasty is completed and the aortic clamp is removed, rewarming is started, and starting from the posterior wall, the suturing of the new pulmonary artery is started. We are suturing the new pulmonary artery. That's how new pulmonary artery is constructed. So now we can see the neo pulmonary artery is arising from the right ventricle anteriorly, and the neo aorta is arising from the left ventricle behind it. This is called as Lecomte maneuver. This is the reverse of the original anatomy. And after the decannulation, the chest was kept open for post-operative pericardial edema to settle down. Patient was taken up for secondary closure after 24 hours of the surgery. Now I invite Dr. Deepika to elaborate.
So your blood gases normalize on the table only. SpO2 goes up as soon as you do the switch.
Saturation.
Yeah, the SpO2, it like improves on the table as soon as you transpose.
Yes, sir. Sure. But after. Yes. Now I invite Dr. Deepika to elaborate on the cardiopulmonary bypass and the post-operative course.
Thank you, Dr. Vini. While the surgeons were performing corrective surgery, our responsibility was to take care of baby's physiological state on extracorporeal circulation. Good morning, everyone. I am Dr. Deepika Mangtani, Senior Resident from Department of Anaesthesiology and Pediatric Cardiac Anesthesia. And I'll be discussing about basics of CPB along with weaning of patient from CPB and post-operative management. Cardiopulmonary bypass. What is the cardiopulmonary bypass? It is a technique in which a machine temporarily takes over the function of heart and lungs thus providing bloodless field during surgery, maintaining systemic circulation and oxygenation, which can be reversed when desired. The basic principles of cardiopulmonary bypass functioning include drainage of venous blood, which is diverted to the CPB circuit via two venous cannula in SVC and IVC. It performs oxygenation of blood, thus acting as an artificial lung. Mechanical pumping action, which maintains systemic perfusion. Heat exchanger helps to induce hypothermia and rewarming. It removes air, debris, microemboli through ultrafiltration. Heparin and ACT monitoring are utmost essential for proper flows through CPB, which needs to be taken care of. Maintaining hemodynamics by continuous monitoring of rate, rhythm, BP, contractility are the mainstays of extracorporeal circulation considerations. Antibiotic prophylaxis should be given during CPB. Maintaining adequate depth of anesthesia is utmost essential. Monitoring of distal organ perfusion as well as coagulation monitoring, neurological status monitoring, temperature management are needed. Pharmacological considerations for anesthesia drugs include altered pharmacokinetics due to hemodilution as well as hypothermia induced during cardiopulmonary bypass, which leads to prolonged drug action. Now comes the most important part, weaning. So weaning, it refers to gradual systemic transition from mechanical pump-assisted extracorporeal circulation back to patient's native heart and lung function. This patient was weaned off from cardiopulmonary bypass, allowing moving from full mechanical support to corrected circulation. Preparation of weaning in this child included de-airing, rewarming, restoration of mean arterial pressure at normothermic levels, adequate ventilation, anesthetic depth and muscle relaxation was given, stable hemodynamics, adjusted pump flows and systemic pressures, metabolic and biochemistry parameters were normalized, all monitors or catheters were in functional state, inotropes, vasopressors and inodilators, IV fluids were restarted. This is a video showing the transition period during weaning. During transition of circulation from cardiopulmonary bypass to heart, gradual reduction of pump flow was done while simultaneously reducing venous drainage, allowing the heart to fill and take over circulation. Initially in this patient, weaning was started from 600 ml, gradually reducing as simultaneous increase in cardiac function was seen, as seen in monitor by return of rate and rhythm. Same was monitored by serial epicardial echography depicting improvement in ventricular function, cardiac contractility and coronary function. Once the pump is withdrawn, conventional approach to inotropic support was escalated on maintaining cardiac output and decreasing cardiac load. To remove excess water and inflammatory mediators, we routinely employ conventional membrane ultrafiltration in our process. After conventional ultrafiltration, de-airing was done in order to decrease the chance of venous air embolism. As the heart began to eject blood and hemodynamic stability was confirmed, heparin was reversed using protamine sulfate. Meanwhile, we were inserting pacemaker wires in order to improve contractility of the heart in post-op period. After the reversal of heparin with protamine, decannulation was allowed to be performed by the surgical team. As we can see, IVC cannula is being removed in this video. As stability was attained, the baby was fully separated from pump. Post-surgery recovery phase, baby was shifted to ICU on mechanical ventilation in open chest condition with inotropes and inodilator support. Continuous monitoring of hemodynamics, fluids, temperature was done and appropriate antibiotic prophylaxis was given. On post-op day 1, after stabilizing hemodynamics, sternotomy closure was completed. ICU care was given with lung protective ventilation strategies. Gradual weaning was done and baby was weaned off from ventilator and extubated on post-operative day 3. Further, baby was recovered and discharged on post-operative day 7. This is a video showing the post-operative echo of baby before discharge. It shows laminar flow in left ventricular and right ventricular systems, and there is no left ventricular or right ventricular outflow tract obstruction. Mild TR gradient of 34 mm of mercury, good flows in branch PAs, normal LVRV function, left arch with no coarctation and no pericardial effusion, with stable hemodynamics. Baby was discharged in a hemodynamically stable condition, feeding well with adequate weight gain. Parents were educated about feeding, weight monitoring, warning signs, and medications. The prognosis of cardiac surgery has an excellent surgical outcome. Survival is more than 90% in modern centers. It leads to normal growth and development expected, but a lifelong follow-up is required. Now I invite Dr. Abhinav Gupta sir for vote of thanks.
Good morning, respected audience. Thank you, Doctor. Now I'll just share a few key takeaways from the presentation of today. So what we have seen today is not just a case, but nearly a reflection of how modern medicine works. Different specialties coming together, giving their inputs, and actually creating miracles. And in this specific case, what we see is that by the teamwork of various different specialties, a child who was not expected to live beyond a few months was actually given a possibility of a normal life. And this, in my little thinking, is what is the real miracle which the modern health has brought to this world. And this particular case is not one of bluff. At Mahatma Gandhi, we have actually developed a really robust and comprehensive system in the cardiac department. And now we cater patients from across different age groups, various pathologies, various types of procedures, and different techniques actually. And by this gradual exploration and the improvements, what we have achieved is that the results of the department now are not only compatible with global standards, but even beat them in a few benchmarks. Cardiac surgery and cardiac anesthesia actually have always progressed hand to hand. And whenever cardiac surgery has improved, the department of cardiac anesthesia is always expected to improve. And over time, our department of cardiac anesthesia has evolved into a specialized unit capable of complementing the demands of advanced cardiac sciences. This synergy allows us to provide seamless anesthesia services to advanced procedures like minimal invasive procedures, transplants, or special cases like the Awake CABG we did last year. And now we are also prepared to extend this further as we move toward supporting the robotic cardiac surgery in the near future. A little message to the cardiac anesthesia people who will be the future to the anesthesia people who might take cardiac anesthesia in the upcoming branches. So I would like to highlight that the Department of Cardiac Anesthesia at our institute provide an environment where advanced infrastructure meets strong mentorship. Through our structured DM cardiac anesthesia program, trainees gain integrated exposure to echocardiography, intensive care, and interventional procedures. And this combination helps to prepare the next generation of cardiac anesthetists to confidently manage complex clinical scenarios. Before I conclude, on behalf of the Department of Cardiac Anesthesia, I would like to express my sincere gratitude to Chairman Sir and the entire management of MGUMST for their continued support and trust on the Department of Cardiac Anesthesia. I would also like to thank the CCR review team for providing us this opportunity to present this special case. My appreciation extends to the departments of Pediatric Cardiology, CTVS, and Pediatric CTVS for the guidance and collaboration in this presentation. A special thanks is always warranted to the Department of Immunohematology and Blood Transfusion, because without their backup, cardiac surgery and cardiac anesthesia will be really difficult to proceed. I would like to acknowledge our OT nursing and technical team whose efforts are integral to our outcomes. And finally, our deepest gratitude to the patients and their families for having continued trust in Department of Cardiac Surgery, Mahatma Gandhi. Thank you very much. Jai Shri Ram.